May I present the first speaker, my dear friend, Professor Massimo Benedetti. He is a President and Scientific Director, Hub for International Health Research. He is an IDF Senior Program Advisor and former chair of the IDF Europe and IDF Vice President. Please, Professor Massimo Benedetti, start.
Thank you, Mr. Chairman and chairpersons for the presentation. And as already mentioned, I'm really pleased and honored to be here. And I want to thank once again the AASD and Professor Inashal for inviting me once again. Now, the lecture that I'm going to present is related to artificial intelligence, and in a few minutes it's not easy to just explore the area of artificial intelligence. So I will try to give you just a flavor on how artificial intelligence can be used in the field of diabetes. I will start my presentation from the last slide of my presentation last year. So which was, how can I proceed? What should I do? It won't move. Okay. So, which was related to personalized medicine, and then all the roadmap to personalized medicine from patient-centered care, team approach, guidelines, protocols, and precision medicine in order to arrive at personalized medicine, which is our main goal. Of course, here there is a step which is missing, which will be introduced now. In order to manage the massive amount of information and of procedure, artificial intelligence can be of great help. Of course, this can bring to highly sophisticated personalized medicine, but also can bring to artificial intelligence managed medicine. And then we can go through this. First of all, what's artificial intelligence? There is not just a single definition. There is a broad number of definitions. I will not enter into all of them, but there is the idea, and then there is, first of all, it was, the first time it was mentioned was in 1956, and then it was considered as thinking machines, which described a machine that can be made to simulate human intelligence. Then there are other, definitions, and which we can find in our vocabulary, and even a definition from Amazon. Amazon is, using artificial intelligence, to organize and to manage all its business. So it's not a single idea, but there is a cloud of different areas where artificial intelligence can be exploited, and with different concept by identifying the human reasoning processes as the gold standard, or to have a more autonomous activity, and then to have independent intelligence. So I'm not going into the details, but then which are the area where at present the artificial intelligence is going to be exploited to build a system that think exactly as the humans do, which is the strong artificial intelligence, just to get system to work without figuring out how human reasoning works, so completely independent, and use human reasoning as a model, but not necessarily as the end goal. So there is quite relevant differences. As a matter of fact, its artificial intelligence is seen as the most, disruptive, technology which will be used in the next 5 years in respect to any other technology. And in diabetes, there's been a growing interest in artificial intelligence, and since the late decades of the last century, now there's been a great increase of the papers publication on artificial intelligence in diabetes. Now there is a massive amount of such publication. As a matter of fact, if there are, there are a number of, in the top 12 ways artificial intelligence will impact healthcare, diabetes is, interested in nearly almost all of them and then I will not go into the details, but definitely, there is room for artificial intelligence to be applied in diabetes. So, when we are talking then of artificial intelligence, we can consider decision support system. So, something that helps us giving information and support our daily activity. Or there are, on the other hand, independent decision makers. So it's something which substitutes us as doctors. This might be a little bit threatening, but this is something that might be real. And then in the middle, there are robotics, which can, again, that based their existence on artificial intelligence. So let's start with the decision support systems and the decision support function in diabetes. Where can be, artificial intelligence be used? In personalization of diabetes management, in favoring adherence to treatment, food, exercise, healthy habits, in the glucose prediction and alarm generation, artificial intelligence-based insulin dose calculators. We know how difficult it can be, to adjust the insulin dose. Clinical decision support to deal with data gathered by sensors. Sensors are more and more diffused. And then to give recommendation in monitoring and alarms. Data mining approach for risk prediction. It's extremely useful to understand whether a person is at risk or not at risk, not only for diabetes, but also for the development of the complication. Big data to model and prevent comorbidities, renal, cardiovascular disease, and so on. In the integration of heterogeneous data for patient personalization, we will enter into this issue later on. And data set for benchmarking to compare our settings each other. So there are, in a recent review, there's been a categorization of artificial intelligence in diabetes care, and we can see that most of the papers published are in automatic retinal screening, detection of diabetic retinopathy, maculopathy, exudates, and other abnormalities from normal findings. Clinical decision support, detection and monitoring of diabetes and comorbidities such as neuropathy, nephropathy, and wounds. Predictive population risk stratification, identification of diabetes subpopulation at higher risk for complication, hospitalization, and readmissions. And patient self-management tool, artificial intelligence, improved glucose sensor, artificial pancreas, activity, and dietary tracking devices. So we had previously from Professor Inas, the description of guidelines. She took some time to describe how, to interpret the guidelines, and then navigation into the guidelines might not be an easy task. So artificial intelligence can help us to identify which is the best solution within the many that can be found in the guidelines for that specific patient that we have in front of us in our daily practice. But also, we can have other more sophisticated activities. I will give you a few examples. I could give you much more, but just to have a flavor. Carbohydrate estimation by a mobile phone-based system versus self-estimation of individuals with type 1 diabetes mellitus. It's a comparative study. So this telephone can identify the food, and then can, from the picture of the food, it can then have the recognition, and then can estimate the volume, and also can estimate the carbohydrate amount that it's in the meal of the patient. And today, everybody has a mobile telephone. I remember decades ago, I was in front of an audience more or less your size, and then I did ask how many people had a mobile telephone. Just one or two raised their hands. I do believe that just one or two will raise their hands if I ask who has not a mobile telephone in their hands, in their pocket. So now this technology is fully available, and then it's what is necessary is to apply the applications. So the development of the clinical decision support system for diabetes care. So we can, include into the system all the information related to a single patient, and the intelligence can do the job that we should require, quite a long time for us to detect, and then provide all the relevant information. But also, it can enter also into more sophisticated problem for ontologies for social, cognitive, and affective agent-based support of child diabetes self-management. So we are entering into an area where we are exploring so-called soft indicators, but through artificial intelligence. Then we can also use the artificial intelligence to predict, for progression to type 2 diabetes. So this is machine learning using electronic health records, and then this can predict. You can see two different subjects that they have, a different risk based on, some parameter like blood glucose, triglyceride, blood pressure, and history of lipid disorder. So we can really identify those patients who can progress to type 2 diabetes. Then there are approaches to fully automated personalized health coaching for adults with prediabetes. So we know how difficult, we have been talking about how to educate. Then we can, the person, with the risk of prediabetes can have a continuous support in terms of advice on exercise, advice on nutrition, but not just telling what to do, but identifying what has been done during the day, during the month, and then say, well, you need to do something more, or to do something less, to eat differently. So this is, a personal trainer. And then there are machine also for the daily management of the person with diabetes, so which is machine learning-based prediction of a missed schedule clinical appointment by patients with diabetes. You know that they can miss appointments, and then through artificial intelligence we can understand which are the reasons for this to happen. Then again, there is the meal detection to drive, the multivariable adaptive artificial pancreas control. So through the different meals identification, this can help, the sophisticated. But also we can drive, feedback insulin infusion by considering the different amount of exercise. So all this information can be immediately fed into an artificial pancreas. Then we can also use artificial intelligence for develop a predictive model for diabetes complication. So we can have a model, but then on the right-hand side, we can apply this model to the single subject and to understand which is the risk for this person based on this model to develop complications. And not only in general, but we can understand through different algorithms which can be the evolution of an already established complication, in this case kidney disease, and then we can predict which is the survival and which is a 6 months aggravation of complication. Also, this can be applied into all the other complications. Then we can have a highly qualified methodology to better evaluate the status of the health of the person with diabetes. Then let's go to the next, which is robotics and cyborgs. I mean, this is not science fiction. I mean, just a few months ago, there's been the FDA approval for an artificial intelligence device which can detect and diagnose diabetic retinopathy. So it does everything without, the support of the ophthalmologist. So is this replacing the ophthalmologist? I mean, for certain, function it can. Then the other point is, in robotics. I mean, a new generation for prosthetics. I mean, they can replace a limb by replacing also its functionality, and this is something which relates to the bidirectional brain-computer interface. Now, the brain can directly have a dialogue with a computer. This can be done with sensors which are applied directly on the brain, and then it can then send information and can receive information. It can receive information in terms of sense, but it can also deliver information in terms of movement. And this is something which can be applied to peripheral nerves, but also directly to the brain. Is this science fiction? Well, now we do have prostheses which are absolutely can work like a normal limb. I mean, we can climb, we can also watch what we are taking, and then we can do sport, and then this is not just for young people, but also can replace completely the arms of more old people. And this, of course, we know how amputation are life-threatening and limiting the activity of the people with diabetes. But this is not just the case. And then if we do consider the vision, the eyes. So what are the eyes? The eyes are simply sensors. They can interpret the reality that surrounds us and then sends the information to the brain. Now, if we do have a chip, microchip in the brain, then we can substitute today the sensors, the natural sensor of the eyes, with artificial sensor. This is not science fiction. This person here is a person who has succeeded in having his picture in the passport in UK with his prosthesis. So this is part of his own identity. So because he has a microchip placed in his brain. Again, this is not science fiction. If you do consider people with the hybrid artificial pancreas, already there is a machine which is applied to the body who decide, according to the continuous glucose monitoring, what is to be done in terms of insulin infusion. So again, this is nearly a cyborg. We can expect that the production of artificial organ will increase in the next years, and it is expected by 2022 there is available by artificial pancreas. Then, in sequence, there will be, the implantable artificial heart, and then the wearable artificial lung, artificial kidney, and the implantable artificial kidney. So this will, at least, support the people with diabetes with end-stage complications. But then the last part is the independent decision maker. So machine learning and pharmacogenetics will enable a system with artificial intelligence to manage diabetes better than human beings. What happened?
Time's out.
Can you stop playing the games?
Can you give him 2 minutes, please?
1 or 2 minutes more, please.
How many minutes you need?
Yeah, here we are. To manage diabetes better than human beings in the next 20 years. So this is an artificial, it's a brain. Then there is something which is your substitute. And the people with diabetes, since the younger age, will rely on this intelligent robot for care. But is this really what we want? We know that health and illness, they are determined by different factors. Of course, we have biological characteristics that can be measured, but also we do have psychological factors which are much more difficult to measure, and we have social conditions that are even more difficult, but we know that they do have an inference into the onset and in the evolution of the disease. So, decision-making processes based exclusively on quantitative metrics that ignore qualitative factors could create a quantitative fallacy from qualitative to quantitative. Difficult to quantify inputs into an artificial intelligence-based therapeutic decision-making process include empathy, compassion, experience, and unconscious bias. This is what we do apply in each everyday practice. So failure to consider these softer variables could lead to important errors. In other words, what is not quantified about human health and behavior is still part of the calculus for determining therapeutic intervention. So, in conclusion, I will leave you with the 3 questions. So, if you are interested in the answer, you will invite me next year. So, can the role of empathic personal relationship be neglected? So we know how important is the face-to-face, relationship with the people we care of, and then the transfer, the bidirectional transfer of information. Can an empathic man-machine relationship be established? Do we believe that the eye contact that we do establish with the people we care of and the signal that we send can be replaced by the artificial intelligence? So, eventually, is medicine ready for the artificial intelligence in the future? Who will have the final word in a clinical decision delivered by a computer? We know that the computer has an intelligence which can be completely different from one to the other computer. So is the computer always right? Will the all-knowing machine be closing the loop, or will the wise clinician still have a role to play? So will we survive with our functions? So will, this is another point, the insurance companies or the hosting hospital be the ones to configure the algorithms? And this can be a little bit dangerous. And will the patient still have a say? So that are the question I leave you with, and I'll give you the answer next year. Thank you for your attention.